Okay, well, thanks for joining me tonight, everyone. Appreciate your attendance and look forward to some discussion afterwards. So, tonight we're going to talk a little bit about implementation of nasal high flow before, during, and after COVID-19. And my name is Dr. Matt Trump, and I'm a pulmonologist with the Iowa Clinic. And we're based in West Des Moines, Iowa, and we work through several hospital systems in the city and throughout the state of Iowa. So, thanks again for your time and looking forward to it. And we'll get started. So just to disclose, I am a consultant with Fisher Paykel Healthcare. And just a little bit about my background and where I work, what we do. Iowa Methodist Medical Center is the main hospital that we work at in the state of Iowa. It's a level 1 trauma center. It's got 370 staff beds. It's ICU is a combination of medical and surgical patients, about 36 beds. And we are one of 3 referral centers for the entire state of Iowa that receives patients throughout the state. So pretty high level of acuity and in a large geographic area that we help cover and take care of patients. UnityPoint Health is the umbrella of the health of the hospital systems we work at. As you can see, our territory covers the state of Iowa, and we have locations in Peoria and Wisconsin. That's Peoria, Illinois, and in Wisconsin. So 3 states is covered by UnityPoint Health, so there is a quite extensive coverage for the health system that our hospital is under. So today we are going to talk about nasal high flow. We're going to explore the mechanism of action of nasal high flow. We're going to examine the clinical evidence that's out there for use of high flow before and during the COVID-19 pandemic. We're going to present nasal high flow as a resource-sparing option, and we're going to display some additional opportunities for clinical application. So we're really looking forward to sharing some of our experiences that we've had at our hospital. Just a quick background too is that we use nasal high flow in every ward in our hospital that cares for adults. So the pediatric side also uses it too, but we have been using high flow since 2010. So we're really excited to share our experience. So nasal high flow, there's a lot of benefits to its use. What it does is it provides adequate supplemental oxygenation. It provides a stable FiO2 that is also higher than standard oxygen, and it reduces the entrainment of room air, and we'll kind of talk about how this works in a little bit. It provides respiratory support that matches patients' inspiratory flow demands when they're in respiratory distress, and it decreases work of breathing. It also improves alveolar ventilation with a reduction in dead space. It improves lung recruitment, and there is a CO2 reduction of about 6 millimeters of mercury that we see with high flow use. And high flow is lung protective as it avoids injurious tidal volumes and airway pressures that can injure the alveoli. So high flow also is comfortable. It's more well tolerated than non-invasive ventilation, and that's been seen in many studies. It also provides adequate airway hydration. With standard oxygen, there's a lot of drying out of secretions that can occur, and high flow helps provide the necessary humidity to maintain mucociliary clearance. It also, high flow allows people to be mobilized and up and moving around, and it allows people to eat and drink and maintain their nutrition status. So overall, what high flow does is it's not in place of breathing. It supports spontaneous breathing. It reduces dead space. It provides a little bit of positive airway pressure, and it hydrates the airways, and it's comfortable for the patient and provides supplemental oxygen in the spontaneously breathing patient. So high flow will match the inspiratory demand in patients, and it will provide adequate supplemental oxygen. When people are in respiratory distress and they're breathing in very fast, if they're on a standard oxygen device, they will breathe in not only the oxygen, but they will also entrain room air. And on the right side of this chart, what we see is at these high flow rates, when there's high inspiratory demand, high flow will provide adequate FiO2. On the left, when people are breathing fast and on conventional oxygen, there is variable inspired oxygen that is taken in because of that entrainment. that can lead to unreliable amounts of FiO2 the patients are receiving. So we actually get a benefit with improvement in FiO2 concentration that's reliable with high flow. High flow also provides dynamic positive airway pressure. What happens is it provides a reservoir of air in the nasal pharynx that we breathe in, and that allows the air and the water vapor mixture to get down to the alveoli. This is breath and flow dependent, and this promotes slow and deep breathing, and it increases alveolar ventilation. When people are tachypnic, they breathe fast and shallow, and this is inefficient, and it contributes to worsening overall status. When people are on high flow and they're tachypnic, the efficiency significantly improves with the device. We get a significant improvement in dead space, and we're going to see this on a representation here that is screenshotted here in the middle. But again, what high flow does is it washes out the upper airway, provides a reservoir of air and water vapor and oxygen mixture that we're allowed to breathe. And this is allowed, what this leads to is a clearance of dead space and allows for better alveolar ventilation. And you avoid rebreathing of carbon dioxide that can potentially happen with the slow and fast breaths and tachypnea. So in this diagram, what we see is in the control patients in these representations are tagged gas. We see all that gas is staying in the nasopharynx. But as we move over to the right, what you saw was that all that gas is cleared out with at least 45 liters per minute of flow of high flow. The airway pressure that's actually delivered is variable, and that it varies based on whether or not the patient's mouth is open. If the patient's mouth is open, the air will leak out the mouth, but it does still provide some positive pressure. At lower flow rates, the amount of pressure that has been identified is listed on the right, and then as we increase, there is a slight increase in pressure as the flow rates go up. What also we see with high flow is improvement in alveolar ventilation. The first video in here shows low flow oxygen, patients tidal breathing, and the amount of air going in. As we apply high flow to the patient, what we're going to see is improvement in gas distribution, alveolar recruitment. The lungs are opening up better, and this improves hypoxia, gas exchange, and overall respiratory status with the patient because of high flow. With again, with the airway pressure, the overall amount when somebody's mouth is closed is about 0.7 centimeters of water for every 10 liters per minute of flow, and that changes when the mouth is open to about 0.35 centimeters of water for every 10 liters per minute. And overall, this does result in about a 25% increase in end expiratory lung volume, resulting in some alveolar recruitment and a slight PEEP effect, but not quite. Not quite what we see with positive pressure. So this is a graphic that kind of demonstrates how high flow works as compared with non-invasive ventilation. And this is something that we use when we educate our students and residents and other people who aren't as familiar with the device. They ask if high flow is like CPAP. It's not. It delivers it totally different. So what we see in the green graph is how high flow works. What we start off is about 5 centimeters of water pressure in the nasopharynx from the flow of the device. We take a fast breath in, and it actually, because of the negative intrathoracic pressure, the amount of pressure goes down and then rises back up as we exhale and our reservoir is built up in our nasopharynx, as opposed to non-invasive ventilation where you're usually at a set PEEP level. You inspire and positive pressurized air is delivered in that with that breath. So it's a completely different delivery of air and oxygen compared with non-invasive ventilation that is very effective. High flow also provides optimal humidity. It emulates the natural balance of heat and humidity in the human lungs with the heated humidified circuit. This allows that airflow to be comfortable for the patient, and it improves mucociliary clearance. We're going to see why that could potentially be beneficial in a certain degree of patients that we're going to talk about at the end. But definitely we see improved secretion clearance in patients. We use this in folks when they're having trouble getting secretions out, and it certainly is effective. For a more comprehensive and detailed analysis of all the benefits of high flow, I do encourage anybody who's interested in the topic to spend some time with this journal article completed by Dr. Maury in the Blue Journal, American Journal of Respiratory and Critical Care Medicine. What this does is it kind of breaks down all the physiology of how high flow works and provides a lot of good scientific data and rationale for all the principles that are encountered when patients are on high flow. But basically what we do is we have a comfortable delivery system, and as we breathe that high flow mixture and patients are being supported on high flow, there is a load taken off the diaphragm that can lead to some reduction in lung injury because of the way that the air is delivered, the fact that it's not positive pressure down to the alveoli, that reduces lung injury, and we improve oxygenation. Patients' work of breathing and effort is reduced, so that could contribute to less patient-induced lung injury. There's less stress and strain on the patient, less mechanical power being exhibited on the lungs, all benefits that are seen in patients on high flow. Now, high flow has been extensively studied in acute hypoxic respiratory failure, and 2 years ago, there was a very well done meta-analysis, a systematic review and meta-analysis done of all the studies on high flow, and really where the benefit is seen is in patients with acute hypoxic respiratory failure. There is a reduction in not only need for invasive mechanical ventilation, but escalation of respiratory therapy needs when patients are managed on high flow with acute hypoxic respiratory failure. And the key finding in this study is what they found is there's about a 4% absolute risk reduction in the need for intubation when patients are on high flow, and that's a number needed to treat of about 23, which is quite significant. If we can manage enough patients on nasal high flow who have acute hypoxic respiratory failure, who are working hard to breathe, we can certainly save our ventilator fleet and our ICU beds potentially, and a lot of resources. The other thing that's coming clear is that when patients, and when I mean patients, I specifically mean adults for the sake of this topic, when they're managed on high flow and they're in respiratory distress, what we see is that usually they're needing about 50 liters of flow to meet their inspiratory demand. And most of the studies looking at high flow, especially in COVID and other forms of acute hypoxic respiratory failure, most of them start off in patients, most of them start off with a liter flow, about 50 liters per minute, and then adjustments are made based on how the patients are doing. And this is a common question we run into is, where do you start for liters per minute of flow, and how do you make adjustments in these patients? Well, it's pretty common and clear with the evidence that's out there that 50 liters is usually a good place to start, and then as their status is changing, you make adjustments based on that. So what we do is we, when we make adjustments on our patients on high flow, we start them off at 50 liters per minute, and then if their work of breathing is still high, we can increase the flow rate. If there's intolerance or their work of breathing improves over time, we can decrease that flow rate as well. And then we titrate our FiO2 to maintain a goal SpO2 of whatever the patient needs. And then we can maintain a certain temperature. So some patients feel the device is too hot. Some people think the temperature is adequate. Whatever it is that they want, we are able to deliver that at a specific temperature. We also reassess the patients frequently. So this has been a key point of emphasis that we'll mention, and I'll point out as we go along is these patients are ill, they're breathing fast, they're pretty sick. And what we want to see is we want to make sure they're improving so that we're not delaying potentially an intubation, because we all know that in certain patients, if you delay an intubation, it could be associated with harm. But what we find is that as we reassess them, most of the time these folks get better and get to avoid the ventilator altogether. And one way that we have been really finding beneficial to evaluate these patients is the ROX index. rather than just kind of eyeballing the patients and saying, well, they look good, they look bad. We have some really high quality measures to look at a patient with some specific numbers that can kind of guide us and say, okay, well, this patient's still kind of trucking along, and or if they're breathing fast but slowly getting better, we can kind of use this ROX index to really help serve as a good benchmark as to, are they going to be able to stay on the device, or are they going to fail, to help understand that better. So in our facility, we use respiratory therapists to provide a clinical assessment. They see the patient. If it's asked that the patient be put on high flow, they'll go down and assess the patient. They'll give us a call from pulmonary, and then they'll start the patient on the device, and then they're usually with them and making adjustments for the first 30 minutes. We do get a blood gas before they start to make sure that high flow is the right way to go for the patient, that they don't need a ventilator. And then we do get a blood gas after 30 minutes. And we do have a flow sheet that gets entered into for every patient that's on high flow, that puts in data into our EMR, and that's readily available for us to use and look at as we see these patients going forward. We don't require any additional monitoring when patients are on high flow. If they're in the ICU and they need to be in the ICU for other reasons and they're on high flow, all those patients are monitored on continuous pulse ox. But our floor patients, we don't need additional monitoring unless it's for a specific indication. If it's a cardiac patient and they're having an arrhythmia, sure, they'll be on telemetry. But what we use for monitoring these patients is bedside assessment and clinical assessment. And so what we want to definitely see is improvements within about 30 minutes and in their clinical status. We also want to see their pulse ox get better, and we'll look for a blood gas change as well. And then we will calculate the ROX index during every assessment. When a patient is in our hospital with COVID, they get it checked every 2 hours. When they don't have COVID, it is 4 hours for a reassessment unless their clinical status changes. So we did amend our protocol to assessments every 2 hours with COVID, just because of how much their conditions can change. This is the data that was published to bring forth the ROX index to us. And what we see is the ROX index is a dynamic variable that changes over time. And early on, what we can see in folks is the ROX index can be lower, but over time it can improve. So we always want to see improvement. What we also know, or have a good idea of, is overall, if their ROX index stays above 4.88 and they're managed on high flow, that's pretty high likelihood that they're going to be able to stay off a ventilator and be managed just on the therapy alone for their respiratory support needs. But after 2 hours of start, if they're still breathing pretty fast and their ROX index is pretty low, it might be time to intubate them, and that could be a time to intervene. But the point here is that we continually check this and watch people while they're on this, and it's a great guide for it. So these are all the validation charts here on the left. Those are readily available. I won't belabor this too much, but again, if most people, if they're above 4.88 on the ROX index, are available to avoid invasive mechanical ventilation. Then just last year there was a little more information put out on the ROX index, and this concept was published here about the change in the ROX index. So again, what we typically see is a lot of these folks who come in with hypoxic respiratory failure, they just need time. They just need time for whatever it is that they're suffering from to get better, whether it's improvement because of antibiotics, whether they need to have diuretics placed that need to have time to work, or the steroids for their COPD or the bronchodilators. Usually those things can take a few hours to really kick in and take effect, but as long as we're seeing improvement during our assessments of the ROX index, that's really what we want to see, and it's a pretty good guide to help us make well-informed decisions as to whether or not this is working and need to keep going. So I'll just leave that, and I won't belabor this too much. But again, just knowing that you're wanting to see improvements in the ROX index as time goes on, and that's really going to be an effective way to manage your patient and feel comfortable doing it. How about complications? Very few complications. Most of them are associated with just discomfort on the device. This is from most of the studies being done from the systematic review. But most of them are really just from the therapy itself. But we typically don't see a whole lot of of detrimental complications from the device itself. And most of them, when compared to conventional oxygen, are either less or equivalent. So now we come to COVID-19, and we all know what COVID-19 is, and we've all been managing this and dealing with this, and hopefully most of us are kind of on the tail end. But what we're going to do is spend a little time talking about how high flow has really impacted patient care who has COVID-19 and hypoxic respiratory failure. And we're going to look at some of the studies that help us understand the role of high flow and its use. And we'll talk about kind of our experiences with COVID in these patients. But we all know COVID's mostly a respiratory disease, and you know, it does have a pretty significant mortality, about 1.8%, and that's significantly higher than most of the respiratory viruses. And then we also know that about 1 in 5 patients will have severe disease, and the risks of patients developing severe disease do depend on the patient's age and comorbidities. So we all were managing most of the patients who got very sick from this were either older, or they were in their middle ages and they were obese, diabetes, all those sort of things. And we continually saw these demographics continue to play out. And what we also know is the COVID respiratory illness has a few distinct features that were identified by Dr. Gattione. If somebody progresses to severe COVID, they get this pneumonia that has been described as a low elastance state, low ventilation perfusion ratio. They get quite hypoxic, but their lungs are pretty low in weight so far, and but there's not a whole lot of recruitability. And this happens early on in the disease, and what we experience is that a lot of these patients, when they're at this point, do benefit a lot from high flow. But once they develop this type H COVID pneumonia, this one that is more in line with our classic ARDS type picture, is high elastance state, stiff lungs, very heavy lungs, but very recruitable. These are the ones that really respond well to positive pressure and invasive mechanical ventilation with low protective lung strategies. And so again, some early on data came out of Italy that was published that kind of gave us some more clues as to the sort of spectrum of lung injury that happens with people with COVID. And really what we know better now is early on we have this L type of acute respiratory distress from COVID, but it can progress to the type H. And it's not just purely one or the other, it's more of a spectrum, and we see patients all across this. But hopefully, and as we've seen it, we see a lot of patients who mostly start off with severe hypoxia. We treat them with the evidence-based medications that we know work well, and most of them are able to be effectively managed on high flow and don't necessarily have to be intubated, but we also know when to proceed with that too if we need to. So one of the things that came, one of the management strategy early on in COVID, when the pandemic first started, is an intubate early approach. And part of this was to reduce infectious transmissions to healthcare workers and to manage these, but part of it was because we just really didn't know how to manage these patients yet. But what we found out quickly was that intubating everybody who was severely hypoxic with COVID right away it got our hospitals overwhelmed. It came with a very high mortality, and most of the patients who are managed on ventilators with COVID, even now, are usually on for a good couple weeks before they can come off or require a tracheostomy for a prolonged wean. And so some of the signals came out that, yeah, you could intubate everybody early, but it's going to hurt your hospital pretty bad. That started becoming clear, and a lot of this study was done in places who didn't use high flow a lot right away. But over time, we know that much has changed, and really at our facility, we did intubate a lot of people right away. And then what we did, though, is we kind of looked back at their ROX index and thought, is this really the right way to go? Could we do high flow instead? And we're going to share with you kind of our experiences since then, but it was quite labor intensive, and it wasn't really necessary to intubate everybody early. So what we know now about intubating early, it has been studied. There's been a fair amount of data published on it. This was one of the first studies that came out in Critical Care Explorations. Again, the concern with delaying an intubation in somebody with hypoxic respiratory failure is that it might increase that it would potentially increase your mortality risk. But what we saw and what we see in COVID is really intubating them earlier does not really change their mortality. It increases their patient's risk for having complications, ICU length of stay. But this study itself did show a higher mortality in the intubate early group. Whereas in the patients who were managed just on other respiratory support devices, a fair amount of high flow was used. There was a similar mortality compared to the earlier group. So if they were able to delay intubation, it wasn't necessarily detrimental to the patient. It was more to intubate them early. And now a meta-analysis has been done of all the studies that looked at this intubate early approach, and what they've gleaned from all that data is that there really is no difference on mortality with a delayed versus early intubation approach. And this is seen when there's a trial of high flow or non-invasive ventilation or CPAP. And there wasn't really a difference in duration of mechanical ventilation. And so at the bedside, we saw this too, where, most of the time if they came in hypoxic, we could manage them on high flow. If some did get worse and progressed to invasive mechanical ventilation, then that wasn't necessarily going to increase their risk of dying. It could just be the disease itself. And some people did have to get intubated right away. Some people get sick right away, and certainly they need it, but we have enough ways to manage this that we felt comfortable starting most of our folks on high flow. So this study came out in the Blue American Journal of Respiratory Critical Care Medicine in October. This was out of France, out of Europe, I think in France. And what they looked at again was high flow compared with conventional oxygen therapy. And what they found is managing these folks on high flow did result in significantly less invasive mechanical ventilator use. There was improvement in SOFA scores, and their duration of high flow was about 4 days. And there was a lower mortality trend in managing patients with this hypoxic respiratory failure with COVID on high flow compared to conventional oxygen. How about moving these patients out of the ICU and not admitting them in the ICU? Well, this investigation here looked at a center where they got overwhelmed. Their ICU was full, so they had to manage a fair amount of patients outside the ICU on high flow, and they found that a large amount of these patients avoided intubation. There was a low overall mortality. There wasn't any transmission to healthcare workers, and they saved their ICU resources for the patients who were in shock, who did need ventilators. And we had similar experience with this as well, as we managed most of our patients, even if they have severe COVID outside the ICU, as long as they fall within the range of our protocol. We were able to share our early COVID experience in the summer of 2020. This data was up to July, so it was through our first surge that happened in April and May. We had, again, most of our patients were managed with high flow as the initial therapy, and most of them were able to stay off ventilators, and we were able to manage a fair amount of them at that time on the inpatient ward outside of the ICU. So overall, since then, at our hospitals locally, we've started over 220 patients on high flow with COVID, and we've only need to intubate about 14% of them. And we've been able to manage most of them on the medical floor. Most of the time they're only on high flow for about 3 days. That was our median duration. And survival was about 55%. We did manage a lot of folks who were DNR, DNI, and elected not to go on a ventilator if they got worse. A lot of our patients we managed were older age and had a lot of other comorbidities, that those demographics we typically see with patients who succumb to COVID. And then what we see in our patients is their average ROX when they get intubated is about 2.91. So that ROX index is used and really helps guide us to know when it's time, and that we hope and we feel that we weren't intubating people too early, and we were giving them enough time to see if they can get better. But if they did escalate to invasive mechanical ventilation, the mortality was quite high. I think we had a fair amount of this, especially with our big surge in the fall. But overall, with the health system, you can see that on the right, throughout 3 states, we've had a significant amount of high flow use throughout this time, and it's been very effective and beneficial for patients. So how about these particular patients when we monitor them? How is the ROX holding up? So the ROX initially was validated in patients with just acute hypoxic respiratory failure. And there's been a number of studies that have looked at the ROX in COVID patients to predict failure in going on invasive mechanical ventilation. So the one on the left looked at it. They said a ROX at 5.37 or less at 4 hours predicted failure. The one on the right said a higher respiratory rate, better predicted intubation in their group. The table here shows that ROX outperformed age, sex, pneumonia severity index, Apache 2, and SOFA scores. A ROX index of greater than 5.5 really did a good job of predicting the outcome and avoiding a ventilator. And then Annals of ATS just published in February another table looking at the 2-hour ROX index of less than 4.88. That did best at predicting intubation need, and it was better than respiratory rate alone. So which particular ROX number is going to predict your intubation on a patient? It doesn't really get explained by these multiple studies, but that 4.88 mark is still pretty good. And again, looking at it over time, making sure it's getting better and watching the patient's clinical status overall is really going to help get you the best information. Now, I did want to point out that not all high flow devices are the same. So this study is in journal Pre-Proof here, but has been made available. And they actually found a high rate of failure in patients on high flow in this facility. But they only use flow rates of up to 40 liters. The device that they use only is able to achieve 40 liters of flow. And our clinical experience does somewhat support this. And we saw a lot of patients in other facilities who were started on high flow with COVID and got worse, and were transferred to our facility where we were able to support them on higher levels of flow, and they were still able to avoid the ventilator. So I think the lesson is that if somebody's got COVID respiratory disease and severe hypoxic respiratory failure, they're going to need at least 50 to 60 liters per minute of flow, and they're going to need that degree of support to get them through, and 40 liters is not going to be enough. Now, the other concern with COVID was, when this all started and continues to be, healthcare worker infections and transmission to healthcare workers. What the concern was is that people are breathing fast and coughing, that that was going to be spread to the healthcare workers, and that if we just intubated them, that would help contain things. Well, intubating them is not always the best thing for the patient, and we know that high flow really doesn't cause a lot of aerosolization of respiratory droplets. High flow is not aerosol generating. We're going to talk about that in a second. Nebulized medications, non-invasive positive pressure ventilation, sure, but even compared with masks and nasal cannula, the dispersion of these respiratory droplets is much less when on high flow. This was a study that was just published in Respiratory Care, and what they did was they looked at folks who were healthy and who had COVID and compared the two, and they put them both on high flow, and they found that no aerosols were generated in high flow in healthy and critically ill COVID patients. Sure, when they cough, there's obviously some dispersion, but with high flow itself, there was no aerosol generating. So I think this and other data have made it clear that high flow itself is not an aerosol generating procedure. There is some dispersion of particles and gas, but it only happens at a short distance. So overall, we know that the risk to healthcare workers for transmission of COVID is extremely low, especially when they're provided the personal protective equipment that they need. We mask our patients, and it's recommended to do that when anybody else is in the room. Obviously, our staff wear masks. And with all these patients we managed on high flow at our hospitals locally in Des Moines, we've not had any COVID transmitted to healthcare workers that we've been aware of. So high flow, moving on, just has a number of indications that we're going to quickly cover. There's a very nice review that was done last year in Respiratory Care that kind of covers all the evidence to that point and talked about all the indications and use for high flow. So again, for acute hypoxic respiratory failure, compared with conventional oxygen, high flow does reduce risk of intubation in patients with significant hypoxemia. In patients who are immunocompromised with hypoxic respiratory failure, again, high flow reduces risk of intubation. It is used in planned extubation. High flow is in post-surgery patients and other patients who are at risk. High flow does reduce the risk of developing post-extubation failure in planned extubation, and the evidence is a little mixed for surgery patients, but there's probably some benefit in those who are undergoing cardiothoracic surgery. And then in those high-risk patients, compared with non-invasive ventilation, high flow does pretty well. High flow has done pretty well. There was recently a study, which I won't review now, but it was in JAMA, that showed that using non-invasive ventilation with breaks with high flow is probably a little better than high flow alone in those high-risk patients. But again, there's certainly a role in patients post-extubation why it's to use nasal high flow to support them and reduce their risk of getting re-intubated. Pre-oxygenation before intubation, high flow is certainly better than oxygen alone, but we do use it as a support device in patients. We keep it on them, and we turn it up to 100% when we're getting ready to intubate them. But we certainly don't switch them back to high flow from non-invasive ventilation if they're already on that. COPD, there is a role for its use in stable COPD. It does improve oxygenation in patients with stable disease and reduces exacerbations and improves quality of life. There is some role in the improving exercise tolerance. There is emerging evidence that is showing possibly some, I wouldn't say equivalence, but some comparable results to non-invasive ventilations in patients with COPD exacerbations. And what we're seeing more and more in these studies is that high flow is certainly a reasonable support device for these patients who have COPD exacerbations. and it's a lot better tolerated than non-invasive ventilation as well, and it can avoid ICU stays in a lot of folks. What recently came out in this journal in critical care was a non-inferiority trial that looked at using nasal high flow therapy compared with non-invasive ventilation as the initial strategy in patients with COPD exacerbation. And this was a multi-center non-inferiority trial. And what they found was, and what they were looking at in particular, was the ability of high flow to reduce CO2 levels. And what they found was that high flow took the CO2 down to took it down by almost 7 millimeters of mercury, a little above the 6 that we previously described. But what they saw was that this was non-inferior to the to that of non-invasive ventilation. And they used 60 liters per minute of flow. So again, these folks required high amounts of flow. About a third of these patients in the high flow group did have to get switched to non-invasive within 6 hours, and a little over half did require non-invasive at some point. There was a low level of people requiring intubation, and then there was even a small percentage of people who switched from nasal high flow back to non-invasive, or excuse me, switched from non-invasive back to high flow because they were unable to tolerate it. And this came at no expense in terms of mortality, hospital length of stay. So really, what I think this signals is that high flow is definitely an option for patients with COPD exacerbations. And in our facility, especially, if we'll start them off in the ER on high flow, give them their steroids and nebulized bronchodilators. A lot of them get better within a few hours and are totally able to avoid the ICU. So overall, what we're going to talk about next is our experience in using using nasal high flow outside the ICU. What we saw early on in our hospitals when we started using high flow is we used it only in the ICU for certain people, and what we observed and thought was we could probably manage most of these folks on the floor because most of them are just hypoxic. And so we thought we could do it, and we put in our implementation process, and we were able to share our experience in this paper here. But what we did was we found a significant amount of patients were able to be managed outside of the ICU on high flow, and it was safe and effective. So of the patients who we looked at, to start with high flow outside the floor, about 66% avoided the ICU altogether. We were able to spend 486 total hospital days in this study outside the ICU, and most patients were only on it for close to a couple days, and very few needed escalation of care. And when they did, we quickly recognized it and got them to that point. And overall, the mortality was pretty low. So we were very excited to share experiences that these folks, when we were managing them on nasal high flow per our protocol, as long as they met the criteria, most of them are able to be managed outside the ICU. So we do have a pretty strict protocol that we use in our patients who are managed outside the ICU. We have our usual indications for managing patients on high flow. The first one being that, traditional nasal cannula cannot meet their flow demand or FiO2 requirement. We look at this, especially in patients with COPD and asthma, because these folks do get turned around pretty quickly, and sometimes they just need a little extra help with high flow, and we can get them better within a couple days without having to have them go to the ICU. Other respiratory infections and other cardiopulmonary conditions too. So we do use this a little bit in our heart failure patients and pneumonia patients. We also use this in our trauma patients with rib fractures or pulmonary contusions, and we feel that this helps splint open the airways a little bit. We use high flow in other forms of shortness of breath or states that there's increased work of breathing. And what we do is we think about using this in anybody who's requiring more than 4 liters per minute of oxygen. That 4 liters per minute cutoff is what we found in our institution, and we were able to study this. If we start this early enough when they're needing more than 4 liters. We can reduce ICU length of stay. We can reduce escalation need and intubation rates and improve outcomes. So if we get to them early and get intervening on them and get pulmonary involved, or and get to the patient who could be developing distress, usually the outcomes turn out to be a lot better. So we use them again in PF ratios more than 150, and we do start them off in the ED as well, especially if they're not tolerating invasive mechanical ventilation and they're not needing much in the way of CPAP. So some of our ambulance crews in the city do have CPAPs on board, and when people are in respiratory distress, they'll start them on that. They'll hit our ER, and we'll transition them over to high flow, and they do pretty well. We also use this to help improve secretion clearance, and we do use this in our tracheostomy patients. We think the humidity and heat is much better for airway clearance, and as we'll see, there is evidence that using high flow is emerging, that it may, and suggesting it may improve decannulation times. And then we also use high flow for palliation. Now, when we don't use high flow is when the patient's not awake and not maintaining their airway. They can have a severe respiratory acidosis to use on the floor. If sometimes we will use this with a respiratory acidosis, but we'll keep them in the ICU if their pH is less than 7.3. But as long as it's above that, we'll be able to keep them out of the ICU. They've got to be hemodynamically stable. They can't be in shock. They have to have an intact upper airway and not have any facial fractures. So we've, in particular, in our study that we published up to that point, that was up to 2019, right before COVID. Looking at close to 1,000 patients, we've been able to study them, and really what we're interested in looking at is in patients with COPD. We've managed at least 90 of them with high flow outside the ICU. We've looked at trauma patients, and then we looked at the ones that we started off in the ED as well. And we shared our early experience with high flow in COPD patients, and what we found is in patients who had COPD and hypoxic respiratory failure, we're able to keep most of them out of the ICU and manage them on the floor and not have an increased risk of mortality or complications. And then we also use it in our trauma patients and keep them out of the ICU as well. There's a significant reduction in ICU time when we use high flow in patients with rib fractures and pulmonary contusions, again, who aren't in shock or need a ventilator for another reason. But there is some role for high flow that we feel. So transport also became a big area that we worked on during COVID. We would have a lot of patients in rural hospitals, a couple hours away, who had COVID and were getting worse on conventional oxygen and needed to come down to our facilities and be managed. So we equipped some of our ambulances and our helicopters with high flow. So we are able to go and get our patients, start them on high flow and bring them to us. And we found this to be a very safe strategy and very effective. In the facilities that didn't have high flow, sometimes they would be very reluctant to transfer them without intubating them. And this allowed us to send our ambulance crews to the hospitals, start them on, keep them on high flow, keep them away from a ventilator and be managed on the floors. And we saw this time and time again. We also use our high flow in conjunction with non-invasive ventilation. So some people need continuous non-invasive ventilation for a variety of conditions, but sometimes they need a break, and we're able to provide that with high flow. With our V60 non-invasive ventilators, they do have a high flow mode on that, so we're able to seamlessly switch between that without having to get a new circuit out and be able to support patients for whatever they need just with one device. And we do find that very helpful. This was an example of a patient that we had on ECMO who had COVID. He developed really bad pneumomediastinum and pneumothoraces and really bad barotrauma from the ventilator. And we were able to support him intermittently with high flow and ECMO and help better protect his lungs. At least we felt that was the case, let them heal up a little bit and reduce the amount of barotrauma he was experiencing. So another role that high flow is continuing to be explored is with tracheostomy weaning. First in 2013, Dr. Hernandez published his work with not only using high flow, but using high flow with a cuff down and a smaller trach to reduce weaning times. There was a reduction in respiratory infections as well, potentially a swallow improvement. Another study looked at high flow's effect on work of breathing compared with just oxygen. There wasn't really much of a difference appreciated there. But in another investigation, we did see a benefit in those at risk for weaning failure using high flow and improving mucociliary clearance compared with just using oxygen, and they found less suctioning. And then in the fall of last year, a really nice study was done again by Hernandez out in Spain, looking at high flow plus assessing need for suctioning compared with just doing capping trials and looked at time to decannulation. And what they found was that when people were managed on high flows and that the therapist suctioned them as needed, based on their secretion amount, that actually outperformed capping trials alone in the time to decannulation. So they were able to get people's tracheostomies out faster. And what I think the common theme here with all these studies in patients with tracheostomies is that high flow is used in all of them. I think there's definitely a improved mucociliary clearance. We've seen that. We know that it works in patients when high flow is used to their nasopharynx, but it's also becoming more evident that high flow does improve that mucociliary clearance effect even through a tracheostomy tube and can help these patients get those out faster. So again, high flow is an effective support option for acute hypoxic respiratory failure. It's, I think, first line treatment for hypoxic respiratory failure and severe COVID-19 respiratory disease. We also are seeing a lot more evidence emerge for use in specific conditions, especially patients with COPD, and it does help keep them out of the ICU. Patients managed on high flow most of the time can be managed outside the ICU, which can spare those important resources for the patients who need ventilators and pressors. And we're seeing more and more uses for high flow out there that are successful. So I'll be happy to talk with you about any questions and look forward to the discussion.
Dr. Trump, we do have our first question that came in through the chat function, which is, do you see any use for flow less than 40 liters?
Yeah, that's a great question. Thank you. Sometimes with the trauma patients, they'll have them on a little less flow rate. They won't be as tachypnic, and so they'll use a little less flow rate. Some people are not as comfortable on them, but with those higher flow rates, so they'll be on a little less. But for the patient in respiratory distress, with the adults at least, they most of the time need that higher flow rate, and 40 is not going to cut it to meet their needs. So acutely, I would say not in the respiratory distress patients. They're usually not going to be able to get by on just 40. The tracheostomy patients that I had mentioned, sometimes they actually will benefit from not as high of flow rates, and so we'll keep them on little lower levels just to provide the humidity and the FiO2 there. So it would be mainly in the, just anecdotally experience wise, in the some of the trauma patients that we use and with the tracheostomy patients.
Dr. Trump, if you'd like, if you can open the Q&A panel, there are a few more questions that have all come in. Let me know for any reason you can't see them, and I'm happy to read them out to you. Yeah,
so I'll go with the Q&A questions. The first one is the data from influenza similar to COVID, and I appreciate your thanks. I don't know. A lot of the early studies were just mainly in hypoxic respiratory failure, but COVID has that viral pneumonitis. Influenza can cause a bad pneumonitis as well at times. So some of the physiology may have some crossover, but I'm not aware of anything specific to influenza. The next question says, when weaning do you mean flow or FiO2 first or both? That's a great question too. We kind of go by both. So if the patient's pretty tachypnic, we will kind of keep their flow rates a little higher. If we will start moving their FiO2 down, what we typically go in increments of 5 liters per minute and 5% FiO2 as we wean down, and we kind of stepwise wean it down that way. So we usually go in increments of 5 on each as we decrease, and we'll usually do them both at the same time. And then the next question was, why won't 40 liters on vapotherm cut it in COVID? I think it's that it won't meet the flow, the inspiratory demand of the patients and the adults. The adults typically need at least 50 liters per flow. That we saw this time and time again when patients were on other devices that didn't have as high as flow rates as the ones that we are using. They would fail on their local devices and come in, and we put them on 50 and 60 liters, and the OptiFlow devices that Fisher Paykel provides, those can go up to 75 liters per minute too. So sometimes we even put them up to that. But I think it's the inspiratory demand that is met by the high flow at the higher rates of flow. And then I see there's a comment in the chat. The institution usually uses oxygen at much lower flow rates than 40, especially in the ILD patients. I can definitely see that. That being there. Those ILD patients waiting lung transplants are chronically ill, slowly, probably deteriorated at a different rate than the acute people, but that's actually really helpful. And yeah, I can see how that definitely makes a lot of sense. And I thank you for sharing that, because they probably don't need to have all the flow rate, but definitely provide get benefit from the humidity and the FiO2 benefit on them. So that's very fascinating. Do you ever connect the high flow to the tracheostomy tube? Yeah, so that's how we do it. So we use the adapters. The question is, do you ever connect the high flow to the tracheostomy tube itself? Yes, so we use the adapters for that and connect it directly to it. They do have there is a piece that can go over it too, as like the traditional trach masks have. There's an adapter there, but yeah, we go directly in line with the tracheostomy tube.
All right. Well, it seems like those were the last questions to come in. Normally a sign of a very thorough presentation. Thank you again, Dr. Trump, for your time. Thank you everyone for attending of the California Thoracic Society's educational Friday night webinar. We hope you all learned something valuable, and looks like I have one last Q&A that snuck in. Dr. Trump, any thoughts?
Yes. So there is a little data that there's a few small studies that show some physiologic benefits with high flow in patients with acute CHF. And there's not quite the big randomized trial data yet. We do use it in our CF patients, or CHF patients acutely. It depends how tachypnic they are. It's a clinical judgment, because a lot of times they'll get present to the ED in significant distress, and sometimes they'll get put on non-invasive, but other times we are able to wean them down. But our ER docs are pretty comfortable in placing a lot of folks on high flow first. So yeah, we do use it in the appropriate patients, and it's I think it's effective and it has a role. I think non-invasive ventilation does have a well-established body of literature for that, for CHF, but I think there's definitely a role for high flow in a lot of these patients too. So yeah, for sure. Thank you. And thanks for all your questions and very nice comments. I appreciate it.
All right, well, it looks like that was our last question for the evening. So we will thank you all and send you off onto your Friday and your weekends. Thank you again for attending. Thank you again, Dr. Trump. Thank you, California Thoracic Society, and for some support from, of course, the Fisher Paykel Healthcare Organization. Have a great evening, and see you all soon.